team. Keep on shining, keep on sharing, that's the PSE. The heart is our first love. Sound waves and reflections. Together we walk in harmony to unravel an ailing heart. Heart, learning and teaching. It's the mission of the team. Keep on shining, keep on sharing. That's the PSE dream. Keep on shining, keep on sharing. That's the PSE dream.
Good afternoon, everybody. I am Dr. Emmett Pua from the Philippine Heart Center. We thank you for joining us this evening. We hope everyone is doing well. As you know, this COVID-19 pandemic has greatly affected the way we interact with each other. So using technology to adhere to social distancing rules allow us to present this webinar at the comfort of your own home. But before we continue, may we ask everyone to pause for a short prayer. Once again, good afternoon. In order for you to participate in our discussion, we would like to show you briefly some of our house rules. For your questions, comments, and responses for our speaker, you may type via the chat option found on the right side of your screen. And if you have any problems or technical issues you may encounter, please send a message or call our IT help desk using the number that you see on the screen. At the end of this session, there is a brief feedback form that we would like you to accomplish to be able to get your certificate of participation. To formally welcome all of us, I'd like now to ask our President, Dr. Aurora Gamponia, to give us her welcome remarks.
A pleasant good afternoon to everyone. Welcome to the first webinar of the Philippine Society of Echocardiography in collaboration with the Philippine Heart Association. And we welcome you to this webinar. It is our mandate to initiate and continue to inform everyone as the need arises, especially in this time of the pandemic, of new safety measures. And today's webinar will be indeed relevant and timely, even despite different phases of the COVID pandemic in your community. And this will be on the proper performance of a safe but a quality echocardiography. At this point, I'd like to thank the Philippine Heart Association through Dr. Leus, the president of the society, for their support. Likewise for LRI Unilab for the assistance and giving us this platform. So welcome everyone, and we hope we will have a very good discussion. Thank you.
Thank you, Dr. Gamponia. We have another president. We are very thankful that we have Dr. Leus, the current president of the Philippine Heart Association, also to give us her welcome remarks.
Thank you, Emmet. Good afternoon to everyone. On behalf of the Board of Directors of the Philippine Heart Association, I'd like to congratulate the Philippine Society of Echo for coming up with this webinar together with the Council on Echocardiography of the Philippine Heart Association. We encourage collaboration between the Philippine Heart Association and the subspecialty societies in coming up with webinar topics that will be beneficial in this time of the pandemic. We hope that there will be more webinars in this caliber to further strengthen the continuing medical education of our colleagues. I'd like to thank the speakers who will be sharing their knowledge, who will be properly introduced by Dr. Emmet, the Chair of the Council of Echocardiography. And also I'd like to thank Unilab for their kind support. And thank you all again to the Philippine Society of Echo, headed by my best friend, Dr. Gamponia.
Thank you, Dr. Leus. We have a very exciting session this evening. Our session is further subdivided into 4 topics. I'd like to introduce the speakers. We start off with Dr. Donnie Magno. He will discuss the general principles of quality and safety. Dr. Magno is a clinical associate professor of the University of the Philippines College of Medicine, an associate professor of the Philippine Women's University, and he's the current executive director of the Cardiovascular Institute, Angeles University Foundation Medical Center. He is also our current secretary at the PSE. Our next topic will deal with scanning protocols and special scenarios, and this will be delivered by Dr. Mylene Cornell. Dr. Cornell is an active consultant at the St. Luke's Medical Center, Global and Quezon City, and also at the Our Lady of Lourdes Hospital. She heads the Faculty of Relations Committee of the Department of Medicine of St. Luke's Medical Center, Quezon City, and is also a member of the Institutional Ethics Review Committee. She currently sits as one of the directors of the PSE. Our next topic will be delivered by Dr. Joni Boten Nunez, who will tackle on special considerations for pediatric echo. She is the current vice president of the PSE and is an active consultant at the Department of Pediatric Cardiology at the Philippine Heart Center. And our last topic will be delivered by Dr. Rylan Jasper Ubaldo, who will focus on equipment handling and sonographers' safety. He is one of our lead sonographers at the Non-Invasive Diagnostic Cardiology Division. He holds a master's degree in public administration, and he is the sonographer representative of PSE. So I'd like to turn you over now to Dr. Magno for the first topic.
Thank you very much, Emmett. All right. Good afternoon, everyone. And thank you, Emmett, and the PHA and PSE presidents, respectively, for this opportunity to share our knowledge and expertise to our friends in the industry and the profession. Before we officially begin this series of brief but targeted talks on quality and safety at Ecolab during this time of the COVID pandemic, I would like to recognize the concerted efforts of key sonographers and physicians for making the crafting of the local guideline possible. 28 key opinion leaders, heads, and directors of various labs from 17 institutions all over the country. This PSE PHA interim guide is truly something that we can be proud of, created by the Filipino for the Filipino patient and the healthcare provider. I shall jumpstart this session by introducing some basic principles to keep in mind as we strive to sustain quality while heightening infection control measures in the name of patient and provider safety during this pandemic. Specifically, I hope that at the end of the segment, we can achieve 3 main learning outcomes that shall answer the questions what, who, and how. What are the key principles in mitigating infection risk at the Echo Lab for all people concerned? Who needs an echo study and which clinical scenarios are indicated? And finally, how should screening procedures be conducted during this pandemic? There are some key principles to remember as we attempt to reduce the risk of infection during echo studies. Let's briefly tackle them one by one. The first, reduce foot traffic and congestion at the laboratory by temporarily discouraging elective procedures, spacing out the schedules, improving inter-unit coordination for outpatient and inpatient procedures to reduce patient waiting times and to optimize workflow. Second, provide appropriate protective gear to staff handling any patient without compromising essential care. Such gear must be readily available if the need arises. Third, compartmentalize staff and work to minimize contamination and transmission by staggering staff schedule and dedicating personnel to specific work areas. Fourth, actively screen patients prior to a procedure for clinical red flags of COVID-19 infection using a tailored screening protocol at the laboratory. And lastly, provide focused echo protocols to minimize exposure time of patients and staff during the course of the procedures. To help you remember these 5 key principles, basically we can decongest, protect, segregate, screen, and focus to minimize the risk of infection while continuing to provide optimal care and echo service to our patients. Moving on, what constitutes an appropriate echo study? From ASE, an appropriate imaging study is one which the expected incremental information combined with good clinical judgment exceeds the expected negative consequence by a sufficiently wide margin for a specific indication that the procedure is generally considered acceptable care and a reasonable approach for the indication. As a general rule, appropriateness of procedures is an integral component of quality service, most especially in this time of the pandemic, we try to avoid unnecessary testing to reduce not only the risk of infection, but to avoid unnecessary expense and anxiety from potential diagnostic traps. In our world of echo, we generally adhere to internationally established guidelines and tailor them to the local scenario and institutional experience. This pandemic, however, has serendipitously pushed prudence to the forefront, such that prompt imaging is now considered only for urgent situations where a specific clinical question demands an answer. So for patients with suspected or confirmed COVID infection, the threshold for doing an echo is much higher than the usual scenarios because of the high risk of infection between patient and staff. The PSE recommends the following 6 conditions which all carry a high AUC score based on international standards. Those patients with unexplained shock or hemodynamic instability. Those with acute chest pain syndromes such as myocardial infarction or pulmonary embolism. Those patients suffering from chest trauma, such as stab wounds and blunt injuries from vehicular accidents. Patients acutely presenting with aortic aneurysm or dissection. Patients with acute heart failure. And finally, those with acute and hemodynamically significant valve lesions, such as your acute severe mitral regurgitation. Urgent or emergent echo refers to the use of cardiac ultrasound for prompt imaging of patients with acute or unstable cardiac conditions. And these exams are generally performed to answer the immediate clinical question and/or to identify causes of acute symptoms. As such, focused exams, or what we call POCUS, where limited views are required to provide targeted information for the rapid detection of significant cardiac pathologies, is considered and very valuable during this COVID pandemic. In essence, to remember this infographic, such studies must be highly appropriate, done for acute or urgent conditions, and performed in an aim-oriented or focused manner. How about the general screening algorithm for echo labs? The PSE's general screening algorithm is valuable in helping us standardize our procedures, harmonize our techniques, and optimize our outcomes. As you will see in the succeeding infographic, the following parameters dictate the workflow and guide decision making, and we will go through them one by one. For any echo request coming into your institution, you should ask yourselves the 3 preliminary questions. Is it appropriate? Is it acute or urgent? And is it aim-oriented? Lack of appropriateness is enough justification to defer the procedure. Non-emergent requests may be delayed or rescheduled. For those which are urgent or acute, a focused exam using a handheld echo, if available, is ideal. This may be done by the attending physician at bedside to triage out unnecessary requests for full studies. Those that need full study will hinge on COVID diagnosis. Patients with negative tests or low probability for COVID may be allowed to undergo more advanced procedures, such as your transesophageal echo, in which case the bare minimum protective gear is level 3 personal protective equipment, consisting of a surgical mask, gloves, and isolation gown. If the procedure is aerosol generating or the patient is confirmed to have COVID infection, the bare requirement is level 4 PPE. The details of protective gear will be discussed in a much later segment of this webinar. So hopefully by this time, we were able to fully comprehend the following: the key principles in mitigating infection risk, Remember, decongest, protect, segregate, screen, and focus. The appropriateness of selected clinical scenarios, asking yourselves, is it appropriate? Is it done for an acute purpose? And can I do an aim-oriented study? And finally, the parameters to consider in screening and preparation for echo, considering the COVID diagnosis, the type of procedure, the level of precaution, and finally, protective gear for your patients and staff. Thank you very much.
Thank you, Dr. Magno. That was very clear. We move now to our second topic. May I ask Dr. Maylene Cornell to deliver her lecture.
Hi, MF. Can you see my slides?
It's loading, Doctora.
Is it good?
It's loading, Doctora.
Slides are okay?
Doctora, we cannot see your slides yet.
Okay. Hold on.
All right. So for the meantime, we'd like to thank Dr. Magno. So let us remember the key principles that he presented. Decongest, protect, segregate, screen, and then lastly, focus. I think those are very important words, especially for our sonographers and also our doctors who are requesting for echo studies. If you have questions later for Dr. Magno, may we ask that you type them on the chat box, and we will forward them to Dr. Magno for the Q&A later at the end of this session. Also, towards the end of our discussions, there is a short feedback survey form which we would like the attendees to accomplish. This will enable PSA to track the attendance, and it will also help us in delivering your certificates of attendance. While waiting for Dr. Cornell, we would like to thank LRI Terra Pharma for arranging and managing our live event tonight. Thank you. So, Dr. Cornell, are we ready?
Emma, can you see the slides?
Yes, we can see already, Doctora. It's it's not on presenter view.
Okay. Just a moment. How about this one?
It's still not on presenter view, ma'am.
Okay.
So maybe while Dr. Cornell is fixing the glitches, we may ask our third speaker to present for the meantime. May I ask Dr. Johnny Botten Nunez to present special considerations in pediatric echo.
Okay.
RD.
Thank you very much, Dr. MS.
Thank you, ma'am.
Okay, good afternoon, everyone. The COVID pandemic has created many challenges to the conduct and practice of an already challenging pediatric echo. Though there seems to be a lower prevalence of severe COVID disease in children as compared with adults, this may mean that a large number of infected children may actually be asymptomatic or minimally symptomatic. And when you combine this with the high viral loads present in the child's nasopharyngeal or fecal secretions, plus the frequent upper respiratory tract infections in this group, and the must-have presence of adults accompanying these children to the lab, pediatric echo scanning constitutes an increased risk of exposure to the staff and the community. My objectives for this session are the following: for you to be able to discern appropriateness and urgency of the echo referral, to adequately screen patients for COVID infection, and understand scanning protocols and advanced echo algorithms in children. As a general rule, transthoracic, transesophageal, and fetal echocardiograms should only be performed if they are expected to provide clinical benefit or alter medical management. The decision to use whether or not to do an echo should be performed during these times is guided by the appropriate use criteria mentioned by Dr. Donnie, provided by the ASE, other medical societies, and our own institutions. So gathering the inputs of local institutions caring for children with heart disease, PSE was able to develop a scheduling prioritization list based on patient symptom status and examination indication urgency. The highest priority is given to the following: the critical cyanotic neonate, first-time patients requiring cardiac diagnosis, patients with acute or recent change in cardiovascular symptoms like heart failure, presence of progressive cyanosis or arrhythmia, admitted patients when echo is crucial in the management, like checking on the status of the ductus arteriosus in PDA-dependent lesions and monitoring the effect of prostaglandin. Recent procedures requiring urgent follow-up, such as those post-surgical complications like pericardial effusion. Safety monitoring for therapy, as in follow-up of patients receiving chemotherapeutic drugs. Asymptomatic but with chronic cardiac disease that requires monitoring, for example, patients with cardiomyopathy, pulmonary hypertension, or severe valvular disease, and to monitor for cardiac complications of COVID-19 and other viral infections such as myocarditis. Next in priority are children with cardiac disease that requires monitoring. For example, Kawasaki patients to look for coronary artery aneurysm and echo prior to an elective surgery or procedure. Low priority indications are routine follow-up of stable or asymptomatic cardiac patients, congenital or acquired, and patients for transesophageal echo prior to an elective procedure. Their schedules may be delayed or deferred. And in cases where the urgency is not so clear, consultation with the referring physician is very important. Echo facilities should establish COVID-19 symptom screening for all patients. This should be done at multiple time points, starting from when the appointment is scheduled, during registration, and upon patient arrival. For sure, our institutions are already implementing symptom questionnaires and temperature checks for all patients prior to echo examination. Patient characteristics that may tag patients as suspect COVID-19 are the following: patients with respiratory symptoms, GI manifestations like diarrhea or vomiting, and Kawasaki disease diagnosis. Patients under high-risk groups, age groups like the neonates, the prematures, and preschool-age children, and at-risk groups like the immunocompromised patients or those with pre-existing chronic illnesses like kidney or heart disease, and those with exposure to adult caregivers who is suspected or confirmed to have COVID-19 infection. The decision to request for COVID testing prior to an echo rests on the balanced judgment of the attending physician or the requesting physician, taking into consideration the clinical likelihood of the disease as well as established local guidelines. The importance of testing is that it affords the opportunity for us to defer examinations in patients who are COVID positive, particularly when echo results are not likely to alter immediate management. Subsets that should undergo testing are those patients who failed the initial screening, symptomatic patients, babies born to a COVID positive mother, and patients referred for aerosol generating procedures like TEE. Rapid tests that detect specific antibodies may be used for emergent inpatient echoes, while the RT-PCR, which takes a longer turnaround time, are recommended for electively scheduled cases. Earlier, Dr. Donnie mentioned that focus rather than full scanning protocols are recommended. However, considering the expanse and variety we have in congenital heart disease amongst pediatric patients, a full or the traditional transthoracic echo is preferred over point-of-care echo unless the physician specified that they only need assessment of ventricular function or pericardial effusion. A time-efficient, comprehensive study is indicated in cyanotic neonates and first-time imaging for congenital heart disease, while targeted views may be done for follow-up studies like monitoring for the progression of cardiac disease and in the assessment of cardiac complications of viral infections. Fetal echo evaluation presents a bigger challenge in terms of scheduling because of a limited gestational period within which pregnancy decision-making and perinatal or neonatal management plans are made. Triage and scheduling of these patients can be determined based on, first, an assessment of the risk level relating to the indication for referral as well as the fetal diagnosis. Second, the adequacy of the fetal anatomic scan done by the OB with cardiac views. And lastly, the gestational age of the fetus. The gestational age critical periods are those less than 24 weeks for pregnancy decision-making and the need for additional testing, like amniocentesis, and gestational age more than 34 weeks for delivery planning of fetus with congenital heart disease. The importance of telemedicine across the three risk levels is evident during remote image reviews, follow-up care, and parental counseling. The low-risk group includes referrals like in vitro fertilization, gestational diabetes, or family history of congenital heart disease. The fetal anatomic scan is then reviewed, and if cardiac screening is normal, we can cancel or reschedule fetal echo when COVID risk is less. If the cardiac structures are not confirmed and the gestational age is less than 24 weeks, approach will be that of high risk. But if the gestational age is more than 24 weeks, they will be reclassified as moderate risk. Moderate risk includes indications when gestational age is more than 24 weeks and confirmed congenital heart disease when gestational age is less than 34 weeks. Among the indications are second opinion for congenital heart disease already identified, increased nuchal translucency, the history of congenital heart disease amongst first-degree relatives, for example, left-sided obstructive lesions or maternal atrioventricular septal defect. Thus, these patients are then scheduled when COVID-19 risk is decreased or after 28 weeks gestational age. Those labeled as high risk includes urgent clinical indications when gestational age is less than 24 weeks and gestational age is more than 34 weeks. This includes known congenital heart disease at risk for compromise or rapid progression, the presence of genetic anomaly, we'd need to assess the heart, fetal arrhythmia, SSA, SSB positive mothers, unsure fetal anatomy scan, monochorionic diamniotic twin pregnancy, especially if there's concern for twin-to-twin transfusion syndrome. For this patient, the next available schedule shall be given to them. And lastly, TEE. Intubated patients or not, TEE carries a high risk of spread of SARS-CoV. That is why we should know whether they should be performed and when and with what precautions. Because of the infection risk, unreliability of caregivers, and vague symptomatology, an institution-specific algorithm should be in place, such as this one from ASE. So perioperative and care and interventional guidance are the only acceptable indications for TEE during this pandemic. Outside of these two scenarios, determine if there are available alternative imaging modalities that can provide information needed. If there are available modalities, defer or postpone TEE and proceed with off-axis transthoracic echo, use of contrast, and CT and MRI. But if there's none, proceed with TEE using precautions as to the peri-op algorithm. As mentioned previously, all patients referred for TEE should have COVID screening, RT-PCR test, during the preoperative screening. All children for TEE are presumed to be positive unless they have a negative COVID test within 48 to 72 hours after the procedure. If negative, proceed with TEE using standard precautions that includes wearing of gloves, mask, eye protection. If the patient has an unknown COVID status, is intubated, already intubated prior to arrival at the OR or the cath lab, probe placement is performed by anesthesia or cardiology to minimize personal performing oropharyngeal manipulations. And for patients requiring intubation inside the OR or the cath lab, anesthesia should be the one to intubate and place the probe, donning appropriate equipment, protective equipment, and powered air purifying respirators or PAPRs. This should be followed by a wait period of 20 to 30 minutes to allow complete air turnover in the room, during which no one should enter. After the wait period, manipulation of the probe may be performed by cardiology. And for COVID test positive children or symptomatic children without COVID-19 test, strict isolation precautions is mandated. All personnel in the OR or cath lab must wear strict isolation gear at all times. And also follow the procedure as done for the previous mentioned. I will end this talk with the 4 Ps that I hope you will know by heart. Plan and prepare, know the indication for the procedure and prioritize patients who need urgent, emergent echo. Protect yourself, your co-workers, and your patient. Screen for COVID, request for COVID testing for high risk or suspect groups. Perform short yet thorough examinations or focus examinations as indicated, and wear appropriate protection. Practice diligently institutional or society echo protocols during this pandemic. They exist for us to follow, for all of us to be safe. And most importantly, pray hard and believe that this too shall pass. Thank you and good afternoon. Back to you, Dr. Emmett.
Thank you, Dr. Junie. Yes, we believe that this too shall pass. I'd like to call on now Dr. Mylene Cornell to deliver her lecture on scanning protocols and special scenarios. Dr. Cornell.
Thank you, Emmett, and good evening, everyone. Sorry for the delay a while ago. So my topics are about scanning protocols and special scenarios. Next slide, please. And these are my objectives: to review the echocardiographic scanning protocols for patients suspected or confirmed COVID-19, to describe how to perform transthoracic echo in patients in prone position ventilation, and to summarize the guidelines when doing transesophageal and stress echocardiogram during COVID-19. Next slide, please. Some of the things you need to do when doing transthoracic echo in patients during this pandemic is to make sure that they receive the standard of care, and this also includes observing patients' privacy. Screen patients, as what was mentioned by Dr. Magno a while ago, and identify patients whether they are non-COVID, suspected, confirmed COVID. A surgical mask is required for all patients, but a mask of higher rating is preferred. No indication of why an echo was requested. Assess if patient is clinically and hemodynamically stable to have the procedure done. For those patients with oxygen, make sure they use a well-fitting mask, and for those intubated and mechanically ventilated, adjust proper mechanical ventilation settings to minimize aerosol generation. Next slide, please. So how to image? Echo studies performed with suspected or confirmed COVID-19 should be as focused as necessary to obtain the need to return for additional views. Each study should be able to answer a clinical question. An experienced sonographer should be assigned to perform the study to minimize scanning time and still be able to obtain images of good quality. Set your machines to time-gated instead of ECG-gated. This will lessen contact with patients by not placing the ECG cables. Target a scanning time of 5 minutes or less. Of course, the shorter the time, the better, to limit exposure for both patient and the sonographer. Next slide. Where to image? So echo studies are done, ideally at bedside, to avoid cross-contamination from patient transport. Let's take advantage of the portability of our machines. This affords a clear advantage to patients because they will not be moved around and thus will lessen the risk of virus transmission. Measurements should be done offline and not at bedside. Next, please. So in patients with COVID-19, what do we image? So cardiovascular disease is one of the comorbidities that has the highest death rate, and patients often develop cardiovascular complications when admitted. Thus, reasons for requesting for an echo study are usually to assess regional and global wall motion abnormalities of the left ventricle, to check right ventricular size and function in patients suspected of having pulmonary embolism, and to check presence and severity of pericardial effusion. Next, please. Thus, the PSE recommends the following views when performing an echo study. One is your parasternal long axis view to assess wall motion of the left ventricle, presence of pericardial effusion, and to see the mitral and aortic valves. Number two is your parasternal short axis view at the level of the great vessels up to the left ventricle, again to assess regional and global wall motion abnormalities of the left ventricle, presence of pericardial effusion, and more clearly the aortic valve. The third one is your apical view, your 2, 3, 4, 5 chamber view to assess the left and right ventricular size and function. Next, please. Subcostal and suprasternal views may not be done unless with specific indications or they serve as the most optimal window for acquisition. Spectral Doppler is considered if you want to assess significant stenosis or regurg or pulmonary hypertension. Next, please. Now we move on to echocardiography in a special scenario. So this is in a prone position ventilation. One of the therapies to improve outcomes in patients with COVID-19 is to place them in a prone position ventilation or PPV. This is considered a challenge to the sonographer because this position impedes transthoracic cardiac ultrasound. And one maneuver to overcome this is to do left shoulder elevation with a pillow. This then forms a space as what you can see in the image on your right to put in the transducer. So once there is already a space for the transducer, keep the skills as you used in the usual supine position. And for left-handed sonographers, you stand at the left of the patient, facing his feet, just what is shown in the figure. Applying the same principle, a right-handed sonographer should face the head instead. Next, please. Unfortunately, EPV can only give you the apical views and no other acoustic window. With this view, you can assess the left and right ventricular size and function. Next slide. For the advanced echocardiographic procedures, such as your TEE and stress echo, so this should only be performed if it will provide additional clinical benefit and can lead to changes in management that would have a strong impact on outcome. Application of your appropriate use criteria, as what Dr. Magno mentioned a while ago. Okay. So always consider the benefits of performing the procedure against the risk. You have the option if you want to postpone or cancel. This actually depends on the urgency and the indication of doing the procedure. You may also consider other alternative imaging modalities that can be used, such as transthoracic echo, CT scan, or MRI, especially if it can answer your clinical question. Next, please. For transesophageal echocardiogram, it carries a heightened risk for spread of the infection because it can provoke aerosolization of the virus. This may happen during insertion and removal of probe or when patient coughs or gags. It may also be transmitted through direct contact with the patient's secretions, resulting in contaminated hands and surfaces. Thus, cross-contamination may also happen whenever there is improper handling or cleaning of equipments. When doing TEE, do not forget to wear your PPE. For this procedure, you are required to wear the highest level or the level 4 PPE. Next, please. During PEE, you may do focus study, but this should be extensive enough to detect and adequately assess pathology. TEE should be done in a dedicated room for suspected or confirmed COVID-19 patients. Some of the surgical procedures in which the benefit of performing TEE may be considered to outweigh the risk are infective endocarditis, Stanford aortic dissection, myocardial complications, and prosthetic valve involvement. Next, please. For stress echocardiogram, this is not considered an urgent or emergent procedure. It may increase risk of droplet spread and exposure during deep breathing and or coughing exercises. Thus, this can also be postponed or rescheduled. Next slide, please. So remember, echocardiography should be performed only when they are expected to provide clinical benefit. Limit your exposure and wear your proper PPE, and of course, follow best practices. Next, please. Before I end, I would like to share these statements which I read from one of the articles published by the American Society of Echocardiography. So dedication to patient care is at the heart of our profession, but we also have a duty to care for ourselves and our loved ones and to protect all of our patients by preventing the spread of the disease. Lastly, next slide, please. The PSE believes that quality and safety go hand in hand in the practice of echocardiography. I think that's my last slide, so thank you for listening.
Thank you, Dr. Cornell. Those words by Dr. Kirkpatrick were very well put and is also timely. For our last session, I'd like to call on now Mr. Rylan Ubaldo, who will talk on equipment handling, and very importantly, sonographer safety during the performance of echo.
Yes, thank you, Dr. Emmett. Good evening to everyone. And as a cardiac sonographer, we must be knowledgeable in handling equipment and the sonographer's safety in time for COVID-19. For my session objectives, they are to discuss the safety practices for the staff and for our echo laboratories amidst COVID-19, to discuss the proper and safe handling of our equipment, and to describe the disinfection protocols of equipment and of the echo laboratory. First, we must consider the workflow segregation. There are safety policies for streamlined staff volume and workload. First is physical distancing must be observed inside our laboratory that is aligned with the concept to reduce foot traffic and congestion inside our lab. It is also encouraged to have a skeletal workforce. Echo laboratories must be temporarily operate with minimum number of personnel that will not compromise essential patient care and services. Some institutions, depending on the size, there are variations on what we can do in rotating our staffs. An example is creating two teams, a team A and a team B. Those staff essentially work as a team and don't cross-reference each other. You can also assign a sonographer per day to scan COVID-positive patients to limit the exposure to other sonographers. And we note staff should be tracked with their health status, especially those assigned to COVID wards. It is very important to exert extra measures to ensure safety and well-being of our staff without compromising the quality of our echo studies. It is recommended that the following staff are available during our office hours. So we need one receptionist or a workflow supervisor that receives and triages our requests for procedures. If our lab caters to both echo and vascular procedures, ideally 2 cardiovascular sonographers are needed, 1 to perform the echo and 1 to perform vascular procedures. If your human resource division permits, sonographers assigned to handle patients with COVID-19 should not handle non-COVID requests. We also need 1 cardiologist, a fellow or a consultant to interpret and read the procedures, especially those echo done at bedside, and 1 utility aide and housekeeping staff to perform the equipment and room disinfection procedure. Our existing ultrasound machines must be assigned for a specific purpose to minimize contamination and risk of transmission. If there are at least 2 echo machines, 1 is ideally dedicated for patients with suspected, probable, or confirmed to have COVID-19. If there is only 1 machine, strict disinfection measures must be placed and succeeding echocardiographic studies must be well spaced out, meaning you have to give enough time for disinfection of your machines before proceeding to another echo procedure. Such dedicated machines should be properly labeled and be docked at dedicated and isolated rooms. It is recommended also to do bedside in all inpatients to avoid cross-contamination from patient transport. And ideally, machines used for inpatients and outpatients should be different. For the staff protection and education, universal hygienic and protective measures are observed. This includes the basic hand hygiene, hand washing with soap and water when our hands are visibly soiled, or doing hand rub with the use of 70 to 90% isopropyl alcohol that must be practiced at all times. We must observe proper coughing etiquette and proper wearing of surgical face masks. This slide shows you a table of the different levels of personal protective equipment or your PPEs that are defined by the degree of protection afforded by the gear. For level 1 PPE are for the staff at the reception, our clerks, our typists, and the doctors at the reading area. So surgical mask is worn. Wearing of surgical mask together with gloves and face shields or goggles are for level 2 PPEs and for personnel with minimal or indirect patient contact. For level 3 and level 4, we use N95 or P100 type of respirators. These are reserved for staffs who will have close or direct contact with patients suspected or confirmed to have COVID-19 or other potentially serious infections, and those who will be performing aerosol-generating procedures like in TEE. Besides the respirators and face shields, double gloving is done and wearing of shoe cover, head cap, isolation gown, and coveralls or hazmats are also needed. These are ideal levels of PPEs, but it may vary depending on your institution protocols. In doing our echo procedure, we must know the proper use of our PPEs, especially when scanning COVID positive patients. Our staff working in the critical care or high-risk units must be well equipped and oriented regarding the proper indication, the donning, the usage, and dosing of PPE as recommended by the Centers for Disease Control. And there are educational efforts that must be cascaded in coordination with your hospital infection control committee. So this is the illustration showing a proper donning and wearing of your PPE gears and the doffing or removing of your PPE in a sequential manner to avoid cross-contamination. We must also define the roles of each personnel amidst the current COVID-19 related health situation. The said personnel are encouraged to perform their predetermined function and good balance and urgency and caution. For our receptionists, they serve as the front line. They receive the request for our echo procedure and they answer phone calls. So the risk is intermediate. For our echo readers, which are the fellows and CRFs or consultants at the reading room, their role is to supervise and interpret the echo done by the sonographers. They have low risk. So for both receptionist and echo reader, they both use level 1 PPE. For laboratory supervisors, their role is to oversee the flow of patient in a daily basis. They may be in contact with some patients in our laboratory, so their risk is intermediate and level 2 PPE is advised. And for us, sonographers, our role is to perform the cardiac procedure or the 2D echo on our patient. We may be asked to assist the physician during special procedure like in TEE. So we have close or prolonged contact with patient with COVID-19 infection, and we might be exposed to droplet and airborne pathogens. So level 3 and level 4 PPEs are recommended. If there are staff suspected or confirmed to be exposed with the infection, we must be educated regarding the warning signs and symptoms suggested of COVID-19 virus. The symptoms includes fever, cough, colds, shortness of breath, loss of sense of smell or taste, diarrhea, as well any history of travel or resident in a country or an area reported with COVID-19 or close contact with person confirmed with COVID-19. There are guidelines that we can follow if you have symptoms, as mentioned earlier. Avoid coming to work and report it immediately to your supervisor. Then your supervisor will report it to the Hospital Infection Control Committee for proper action. Decisions regarding necessity and duration of quarantine, necessary testing, and the terms of your resumption of duty will be the responsibility of your supervisor with due advice from the Hospital Infection Committee. So in our laboratory, we can also designate entry and exit points, proper wearing of our PPE, and performing regular hand hygiene. For preparing and handling of equipment, if available, portable and handheld units are recommended for bedside echo for patients with COVID-19 infection for faster diagnosis procedure to minimize patient exposure and to minimize transfer potential contamination back to our echo laboratory. As we prepare the echo machine, the entire machine must be covered in at least 2 layers of impermeable plastic. The inner layer may consist of a stretchable plastic, for example, a cling wrap, that aligned to the contour of the unit, but not significantly compromise our screen view. The outer layer may be a one-piece plastic that covers the lower parts of the unit, possibly up to the wheels. We also cover the wires and our transducer cable with plastic. So after the echo procedure, disinfection must be done outside the room or in the designated disinfection area of the ward. We disinfect the outer layer of plastic, then remove it from the machine and dispose it properly to the designated trash bin. Then disinfect the inner layer of plastic. We transport the machine back to our echo lab, and second disinfection must be done. If the inner layer is visibly soiled, remove and dispose it and disinfect the entire machine. Afterwards, secure the machine at a docking station, and this docking station should be disinfected daily and must be separate from the storage area of machine used for non-COVID procedures. Transducer covers such as condoms or commercially transducer covers may be used as long as they fulfill the institutionally set infection control guidelines and procedure sterility requirements. Because the transducer and its cables are the most prone to contamination and accumulation of dirt and infective agents, they must be cleaned carefully using vendor-compatible disinfecting solution. As mentioned earlier, ECG is disregarded to minimize contact with patient and to the patient's bed. We may use the time capture setting instead of capturing our clips through the beat setting. We may also use a barrier between the sonographer and the patient. This barrier can be made of acrylic or plastic sheet, provided that it will be cleaned and be disinfected every after procedure. In cleaning and disinfection and care of our machines and other related equipment are important in preventing the spread of the disease. All ultrasound machines shall undergo standard disinfection on a daily basis or intensified disinfection after use with patients suspected or confirmed to have COVID-19 infection. The following are the opportunities for disinfection of our echo machines. It may be at bedside, at the hallway outside the procedure room, and at the docking station. Only designated and well-equipped staff, our utility aides and janitorial services, wearing minimum protection, will be allowed to perform the intensified disinfection procedures for our echo machines and of our rooms. There are also levels of disinfection that must be taken into consideration depending on the organisms being targeted, the duration of disinfection, the risk of infection, and the disinfecting agent to be used. For low-level disinfection, example agents include 70 to 90% ethyl or isopropyl alcohol, sodium hypochlorite, or quaternary ammonium germicidal detergent solution. For mid-level or the intermediate disinfection, most agents are similar to those for low-level disinfection, but the difference is we utilize the intermediate disinfection for a longer exposure time. And for the high-level disinfection, it destroys all microorganisms except bacterial spores. So it is required for critical items or object that enters the sterile tissue or for semi-critical items that come in contact with your mucous membranes, such as endoscopes, including our TEE probes. We can use glutaraldehyde and hydrogen peroxide-based formulations. In disinfection of our labs in our procedure area, the utility or the janitorial staff should thoroughly disinfect the floors and walls with properly formulated solution, mostly containing chlorine-containing agents by mopping, spraying, and wiping. Disinfection must remain on the surfaces for at least 30 minutes. The procedure must be done regularly and as needed. It is also important that the reading room and workstations and all its devices inside, such as the keyboards, the monitors, external hard drives, the phones, chairs, desktops, and doorknobs, are frequently cleaned and disinfected on a daily basis. The sequence of wiping should be from the cleanest surfaces to the dirtiest surfaces, which are the most frequently handled. And remember, do not reuse wipes. And lastly, air disinfection. Having a high efficiency particulate air filters or HEPA filters in our laboratory will improve the air quality, especially when ventilation is inadequate. UV germicidal irradiation following UV products operating protocols can serve as a supplement to standard disinfection processes. As a general rule, UV irradiation must be performed in the absence of ultrasound machines unless vendor-specific guidelines state otherwise. In summary, we must know the basic minimum protective strategy of our healthcare personnel at our echo lab. This includes the basic hand hygiene, the proper coughing etiquette, wearing of PPE properly, and educating our staff regarding their roles in understanding hospital safety policies and protocols against COVID-19. A dedicated echo machine, preferably a portable one or handheld, must be prepared prior to use for PUI and COVID studies and must be covered in 2 layers of plastic, including the transducers. We must also practice disinfection procedures in all our echo machine as well as in our reading areas and workstation on a daily basis or intensify disinfection as needed. And lastly, no PPE, no echo study. We must remember that we need to protect ourselves to better give quality service to our patients. And I will end with this. Safety rules are your best tools. Safety begins with compliance, and safety works when people work together. Thank you.
Thank you, Rylan. Very clear, very useful, especially since our guests not only includes doctors, cardiologists, but we also have, from what I see from the participants, we have some nurses and sonographers also. So we have time for some questions. There is a question here from Dr. Louis Go, and I'd like to ask Dr. Joni to answer the question. So he asked, is amniocentesis performed locally for the fetal diagnosis of potential chromosomal disorders?
Locally, no, not yet. But then actually for more progressive countries, prenatal diagnosis is very important for them, especially in countries wherein medical abortion is permitted.
Okay, thank you, Dr. There's also a question from one of our audience. What kind of PPE is best for performing dovutamin stress echo? I'd like to ask Dr. Magno and maybe Rylan for their inputs.
Hi, thank you, Dr. Offel, for that question. So if you look at the PSE document, it states there in Appendix C of the guideline that the choice of PPE may be dictated by 3 things, either the place, the procedure, or the personnel, whichever requires the highest level. So in this case, a Dobu stress echo will involve direct and prolonged patient contact, so the minimum is level 3 for the sonographer and the doctor. However, if a particular situation does not exactly fit the algorithm of PSE, we go back to good clinical judgment.
Yes, I agree
Thank you.
also with Dr.
Yes.
Magdo with that. And there are some protocols that are mandated by each institution that we can also follow.
Okay, so some of the guidelines may actually differ slightly also for every institution. We have another question for Dr. Given the restrictions on stress echocardiography because of the high risk of aerosolization and the uncertainty as to how long the COVID-19 pandemic will last, do you foresee increasing use of alternative diagnostic and risk stratifying procedures, probably cardiac CT? Dr. Cornell, you may turn on your mic.
As we have mentioned a while ago, we still have to weigh the benefits of doing the procedure against the risk. So it will actually depend on the cardiologist or the requesting physician and its indication of doing the procedure. But I think for others who are actually hesitant to do these procedures, I agree with you, I see that there might be an increase in terms of using alternative modalities such as CT scan and MRI. Or for example, for the vitamin stress, probably nuclear imaging studies. So I think it will still depend on the indications and the urgency of the procedure.
Thank you, Dr. Cornell. Okay. So I think for some institutions who offer both exercise stress echocardiography as well as the vitamin stress echocardiography, there is a trend now towards the shift of mostly doing the vitamin stress echo to rule out CAT. Okay. So let me just check more questions.
Sorry,
yes,
just to add, regarding stress and regarding treadmill and Dobue, I agree with what you said. They usually would recommend doing a pharmacologic rather than a treadmill stress echo.
Yes. There's a follow-up question. How long do any of you think we will have to stick to this strict guidelines? Do you think it will be about 6 months or perhaps even a year? Who wants to answer? Dr. Magno?
So Dr. Loigo is basically asking us to look at the crystal ball here. I would say we take it on a case-to-case basis. So, and that also partly answers Dr. Kuiko's question here for standalone labs. So I would recommend 3 things to be done by any laboratory, whether it is hospital-based or standalone. The first is situation analysis. You need to find out if your lab is ready to accept patients and find out the burden of COVID in your particular area. So not all areas will have high burden of COVID. And if your lab is ready, then by all means. The second is to consider gradual resumption of echo services. Okay, so we cannot go from 0 to 100. We need to gradually shift gears here. And finally, let's help triage patients. So for standalone labs, most of them are going to get elective patients, stable ones. So the standalone labs can actually help us by diverting those patients that they deem to be requiring urgent admission by directing them to their neighbor institution or hospital. And for those who are clinical stable, they can find out whether there's clear benefit for early imaging, in which case, let's accommodate these patients.
Okay. Thank you. Do any of our speakers have anything to add to that? No? Okay, so there's also a question, using cling wrap on our transducers, do they in any way hinder your image acquisition? Do you have lesser quality image because you wrap them in plastic? Maybe we can ask Rylan to answer the question.
It may adhere to the cling wrap. That's why we need to disinfect it. So at least 2 layers of plastic should be covered to the machine. So after every procedure, we must remove the first layer of plastic, then disinfect the inner layer of plastic. If it is visibly soiled, we must change the wrapping or the cling wrap of the machine and put another wrap to the echo machine.
Are the quality of the images the same with or without the cling wrap? What have you noticed so far?
It may be a hinder in getting good quality images for the sonographer doing the echo, but in covering the machine, we must ensure that the monitor is not compromised for our screening view.
Okay. So another comment from Dr. Go, very active. Just to play the devil's advocate, what do you usually define as prolonged contact? Could it be 2 hours or more? So if Dobue is finished for less than 2 hours, do we really need a level 3 or level 4 PPE?
Okay, I'll try to address the devil's question here. Thank you, Dr. Lowy. Very relevant. Okay, going back to the PSE guideline, of which Dr. Go is a part, it states there that generally any echo procedure done by a sonographer should require the minimum level 3 PPE for the sonographer, which means gloves, face shield, mask, preferably an N95 or at least a surgical one, and an isolation gown for all types of echo. So it doesn't matter if it's just a transthoracic echo or a TEE or a DOBU, the minimum is level 3. The only time that you will downgrade to a level 2 is if you are not the sonographer, which means, let's say you are the nurse in and out of the room assisting, or maybe the cardio fellow just supervising. But for all sonographers, the bare minimum is level 3. So in which case, it doesn't matter if the DOBU is 45 minutes or 2 hours, we would still recommend level 3. Basically because we need to protect sonographers. And just to quickly answer one of the questions, was there any report of sonographers getting infected? Yes, we've seen some. The question is, where did they get infected? We don't know. There's no way to really know. That's why we need to keep our guard up.
Okay, thank you, Dr. Magno. Dr. Cornell, do you have anything to add?
Yeah, I think there's actually no direct answer to that question for regarding the number of hours, but of course, we should always follow that we should limit our exposure for both patient and sonographer. So the shorter time, the better in doing procedures. And I agree that when we are doing stress echo, we should be wearing at least level 3 PPE. That is actually for safety for both sonographer and for the patient also.
Thank you, Dr. Cornell. There's a question also here for standalone clinics where there's one machine both for 2D echo and for general ultrasound procedures. So how often do we change plastic coverings of the tubes and the machines? So I think this was already answered earlier, but Rylan, would you like to add a little bit more?
I think my lecture says it all, that we if it's visibly soiled, we must change it, and if our logistic is we have enough cling wrap, we must change the cling wrap every other procedure, every after procedure.
That's right. Thank you, Rylan. For those of us who have a workstation, do you advise using cling wrap on the keyboards of the computers as well?
I think
yes, Dr. Magno?
I think Rylan was gonna answer that. I'll let him.
Rylan?
Okay. It is not advised to put cling wraps, but on a daily basis, the utility staff of our laboratory should wipe and clean it three times in a day, because they are frequently touched by our doctors who came from other wards. So it must be sanitized and disinfected on a regular basis.
Thank you, Rylan. Someone asked about the use of ultraviolet disinfection for disinfecting the machine.
Oh, okay. I actually reached out to several vendors here about this very important question. And not all of them are unanimous. Some would say it's okay to sterilize the room with the machine in it. Some would say no. So I think the general dictum is take away the machine before you do the UV, and just do the recommended wiping down and disinfection of the machine itself, then put it back in.
Okay. Thank you, Dr. Magno. For this one, what do you think is the impact of the pandemic to the future of the echocardiographers and the sonographers in this country? Who would
That sounds like a Miss Universe question. Maybe Dr. Johnny can answer that.
Yes, I was thinking the same thing. I think Dr. Joni would have the best answer to this one. Mom, can you unmute your mic? Dr. Joni, can you unmute your mic?
Sorry. Thank you for that beautiful question. Short term, like for now, we may see it as a limitation, but once we get the idea of COVID sinks into us, then we try to get ways for us to continue with medical education, as well as to learn and to continue to teach echo in whatever ways we can. So this may be a limitation now, but it becomes an opportunity later on for us to be more determined to learn and to teach. That's all.
Thank you. Very well said, Dr. Juni. For Dr. Maylene, what is the recommendation for getting clips when doing an IOTEE procedure? For IOTEE, Doctora. Can you unmute your mic, ma'am?
Emmet, can
Yes,
you repeat the question? Sorry.
Yeah. The question is, what is the recommendation for the clips that you would probably need to get when doing an IOTEE?
Intraoperative transesophageal echo.
Yes.
Okay. So actually, it will depend on the indication of doing the echo. So this will depend on the type of surgery that will be performed also. So for example, you are doing a bypass procedure, then you should focus more on the LV functions, on the wall motion and the systolic function. While, for example, you are doing a valve surgery, then you should be able to get all the necessary views or necessary measurements, including spectral Doppler, in this procedure. So it will still depend on the reason for the intraoperative TEE and the views that you need to be able to have a focus but comprehensive study that is enough to show the pathology and to evaluate the problem of the heart.
Dr. Emmet, you're on mute.
Emmet, you don't have any mic.
So I think the goal of IOTE should be, it should be done as on a goal-directed basis.
Yes.
The view should be on what the surgeon needs for the procedure or
So
what specific procedure.
Focused study, but it should be comprehensive enough to actually show the pathology. And of course, for doing the intraoperative TE, we should know the indication of doing the study to be able to prepare well and to be able to do the needed views for the study.
Thank you, Dr. Cornell. There's another question in general here. Did your diagnostic laboratories for echo increase their prices because of the added precautions for COVID? Dr. Joni, would you like to answer?
No, ma'am, it's the same. No increase. Even if we are required to wear certain protection, it did not affect charging.
Thank you.
It's also considering the problems our own patients are actually facing.
That's right. Very well said again. Okay, so there's another question here. If we really need to put ECG electrodes for a patient for 2D echo, I think this was already answered earlier by Dr. Cornell. So studies are now not ECG gated, but time gated. And time of acquisition is about 3 seconds or 5 seconds at the most. Okay. So if there is no cling wrap available, what would be the next best solution to protect our machine? Maybe we can ask Rylan if they have cling wrap. What would be their option?
They can use stretchable plastic wrap. I think cling wrap is the best in the market that we could get. We can use furniture wrap if we can get one. But if we don't have any plastic to cover our machines, I think we should just follow the disinfecting protocols on what disinfectant to be used in our machines.
Okay, thank you, Rylan. So from Dr. Cristobal, to lessen exposure to the lab, can any one of you comment on remote reading, remote interpretation of the echo studies? So maybe
Okay.
Dr. Magno and Dr. Cornell.
Yeah, Dr. Donald, thank you for the question. Yeah, actually, pre-COVID, it's been done already in many centers in the country. But I think it's gonna become increasingly relevant during the COVID pandemic. Maybe one thing we can explore is remote reading, real time, for those doing bedside echoes for COVID patients, because we don't want to crowd the patient room with a lot of fellows and sonographers. So the recommendation is just one person doing the echo. But sometimes the sonographer will have some difficulties. I think if I can recall correctly, during my fellowship in Heart Center, my paper was actually on remote imaging via FaceTime, and Rylan was part of that team. And what we did was really to guide the sonographer real time if he or she had questions during the imaging. So this is something we can embark on, not only for research purposes, but actually for practical purposes.
Dr. Cornell?
I think the other institutions are already doing remote reading.
Yes.
So this is actually one measure, one way of preventing the transmission of infection, because you would actually decongest the readers from going into the hospital or into the laboratory. And at the same time, they would also be safe at home. So I think we actually encourage remote reading, especially during this time of the pandemic.
Thank you, Dr. Cornell. There's a comment here about stress echo. So the question is, can the patient take off his mask because it's difficult to run while the mask is being worn? I think that was already addressed earlier. Doing an exercise stress echo is actually not recommended because it is highly aerosol generating, no? And we have to shift to other modalities, like maybe dobutamine stress echo or other imaging modalities. Okay, so I think that was time well spent. Let me just very briefly check if there are any more questions that we need to. Maybe we can do last 3 questions. No? So for those of the users who weren't able to get in, the PSE will post a link to this webinar. This webinar is recorded, and we will be later posting a link where you can access this webinar. Also, for your attendance, you can follow it up with directly with PSE. We will be sending your certificates of attendance via email. So you have to use the names that you used to sign in. Okay, and then also lastly, don't forget to accomplish the brief survey that we will have at the end of this seminar. So I think we covered a lot of topics. It was a very interesting discussion. I'd like to call on now to Dr. Magno to formally close our session. Do you have a message?
Thank you, Dr. Emmett, for splendid moderating. I'd like to thank again all our attendees, I think close to maybe 300 or more. My only message to you is let's keep up the quality here and learn and share. That is the mission of the team, PSE. Thank you very much.
Thank you, Donnie. I'd like to thank everyone for attending our webinar. We sincerely hope that you have learned something new tonight. We would like to thank our sponsors, LRI TerraPharma, for arranging and managing our live event tonight. Our behind the scenes guys, Mr. R.D. Morales, Mr. Romel Mangundayaw, and our IT specialist, Mr. Francis Camanian. Thank you. Thank you, Dr. Leus. Thank you, Dr. Gamponia, to the officers of PSE and PHA.
Thank you.
Sir R.D., is there... Thank you, Dr. Leus. Okay, so there's just a brief announcement from PHA. It's about hypercoagulable states and COVID-19. This will be on Saturday at 3 o'clock. Again, with the help from TerraPharma. We have Dr. Elaine Alahar and Dr. Leonard Pascual as the panelists, and Dr. Chonko and Dr. Jezreel Tequiso as the moderators. So before we formally end, sorry, there is a last, Dr. Tukay, can we get back to you on your question? So thank you very much. This is the QR code that we would like you to scan. It will help PSE in preparing your certificates of appreciation. Okay.
Dedicated. Doctors with passion for excellence. For our patients' sake, we are always ready to lend a hand. We are driven sonographers, skillful in echo, creating clear images. Together we work in harmony to unravel an ailing heart. Learning and teaching, it's the mission of the team. Keep on shining, keep on sharing, that's the PSC. The heart is our first love, sound waves and reflections. Together we walk in harmony to unravel an ailing heart, learning and teaching. It's the vision of the team. Keep on shining, keep on sharing. That's the PSC dream. Keep on shining, keep on sharing. That's the PSC dream.
Thank you. Thank you, everybody. Stay safe and enjoy the rest of the evening. Thank you.
Thank you. You have a picture? Picture. Where's Johnny?
Dr. Joni.